All right, today we're diving into a piece of tech that completely changes how we see inside the GI tract: endoscopic ultrasound, or EUS. Now, for any of you in your gastroenterology training, getting a handle on this tool is an absolute game changer. Seriously, it's the difference between just seeing the surface and actually knowing what's going on underneath. So, let's get into it. So we're going to start with a classic clinical problem. You know the one. You're on rounds, or you're in the clinic, and you come across something that could be totally harmless, or it could be something much, much more serious. This is exactly where EUS starts to show its incredible value. Okay, picture this. You're doing a scope on a patient, and you see this smooth, subtle bulge in the stomach lining. Right away, your brain starts firing off possibilities. Is this just a harmless lipoma, a little fat deposit? Or are we looking at something like a gastrointestinal stromal tumor, a GIST, which needs a totally different, much more aggressive plan? Just by looking at the surface, there's no way to know for sure. And that really gets to the heart of the problem with standard endoscopy. I mean, it gives us an amazing view of the mucosal surface, but it's like looking at the tip of the iceberg. It just can't see any deeper. To solve this mystery, we need a tool that can actually peer into the layers of the GI wall itself. And this is where EUS comes in and saves the day. It's a really brilliant combination of two technologies. You've got a high-frequency ultrasound probe that's literally mounted on the tip of an endoscope. So by putting that probe right up against the GI wall from the inside, we get this incredible high-resolution view, not just of the wall layers, but even of the organs right next door, like the pancreas. It's amazing. Okay, so let's get into the absolute foundation of EUS anatomy. You have to understand this 5-layer view. I promise you, this is the key to being able to interpret any EUS image correctly. What EUS does is it takes the complex histology of the GI wall and simplifies it into this really predictable 5-layer pattern. It's all about alternating colors. Dense, reflective tissues, they show up as white, which we call hyperechoic. And less dense stuff, like muscle, that shows up as black, or hypoechoic. Just think of this alternating pattern as your personal anatomical map. So this table breaks it all down. Let's walk through it together nice and slow. The very first layer you see is white. That's the mucosal interface. The second layer, which is black, is the deep mucosa. Then you hit the third layer, which is white again. That's your submucosa. The fourth layer is black, and that represents the muscularis propria, the main muscle layer. And finally, you have the fifth layer, white, which is the serosa. You have got to memorize this white, black, white pattern. It is absolutely crucial for everything else we're going to talk about. All right, we've got the theory down. Now for the fun part. Let's actually apply it. We're going to take what we just learned about those 5 layers and use it to solve a real clinical problem. So let's go back to that first scenario, right? The mysterious bulge. Now that we have our 5-layer map, how do we finally figure out what this thing is? This is where EUS is just so elegant. A GIST, you'll see, typically grows from that 4th layer, the muscularis propria, and it appears black, or hypoechoic. A lipoma, on the other hand, well, it's a fatty tumor, so it comes from the 3rd layer, the submucosa, and it shows up as bright white, or hyperechoic. So just by looking at the layer it's coming from and its color, we can tell these two apart with incredible confidence. It's a total game changer. And while we're on the topic, here are some really high-yield facts about GISTs you gotta know. They're the most common mesenchymal tumor in the GI tract, and you'll find them most often in the stomach. They come from the interstitial cells of Cajal, you know, the pacemaker cells of the gut. And on staining, almost all of them are CD117 positive, which is a super important diagnostic marker. But you know, EUS is useful for so much more than just identifying submucosal lesions. It plays a massive and still expanding role in oncology, especially when it comes to staging cancer. Seriously, EUS is an absolute powerhouse for local cancer staging. Because we can get the probe so close to the organ, the detail is just unparalleled. It lets us see exactly how deep a tumor has invaded and if it's spread to any nearby lymph nodes. And rectal cancer staging is the perfect example. EUS is totally essential for figuring out the local T stage, that's the depth of invasion, and the N stage, which is lymph node involvement. And this information isn't just academic, it's critical for planning treatment. It helps us decide, should this patient go straight to surgery, or do they need chemotherapy and radiation first? EUS is pivotal in making that call. So, as we wrap things up here, let's just boil it down to the core value of EUS. What's the one big thing you should take away from all this today? Here it is. EUS gives us clarity where a standard scope can only guess. It lets us see beneath the surface to really understand the true nature and extent of a disease. And that ability fundamentally transforms how we diagnose our patients and how we manage their care. And that leaves us with one final thought. We've journeyed from just the surface down into these 5 distinct layers. But with new technologies coming out all the time, things like contrast enhancement and elastography, the real question is, what new layers of biological information is the next generation of EUS going to show us? The future for this technology is, well, it's incredibly exciting to think about.